So to explain, I'm Olivia Harrison. I'm the Chief Executive at the Learned Society of Wales, and I'm really pleased to welcome you all to our summer seminar for early career researchers. So for those of you that aren't aware, the Learned Society of Wales ECR network is aimed at anyone who's starting or has recently started a career in research or working with researchers. Most members are working in higher education. I think most that have introduced themselves are from a Welsh university, but the network is also open to those in the public, private and third sectors. And at the moment, we've got several opportunities coming up for researchers to get involved in our work. We will be running other interdisciplinary seminars, also skills workshops and a conference as well. So please contact us if you're interested, and there'll be further details at the end of today. The point of our network and its kind of added value is that it is pan-Wales and cross-disciplinary in nature. So hopefully should give you the opportunity to connect with those beyond your kind of normal institutional colleagues, and of course connect with the broad expertise and experience of our fellows, as you will see today. So we've got a great session planned today. The topic is access to medicines, the impact of social inequalities. And this actually was a topic proposed by one of our ECR network members, who we're delighted will be speaking today alongside two of our fellows. So without further ado, I'd like to introduce one of our fellows, Professor John Harrington, who is going to chair today's session. Professor Harrington is a Fellow of the Learned Society of Wales and has been a Professor of Global Health Law at the Cardiff University School of Law and Politics since 2014. Professor Harrington has published widely on access to medicines and global health, with a particular focus on the implementation of the TRIPS agreement in the African states. Books on this include Global Health and Human Rights, Legal and Philosophical Perspectives, and Global Governance of HIV/AIDS, Intellectual Property and the Right to Health. His current research on health and the nation state after COVID-19 has two strands. Firstly, in partnership with the African Population and Health Centre and funded by the Arts and Humanities Research Council, is analysing the response of states in East Africa to the pandemic, focusing on their diplomatic strategies to secure vaccines and the lockdown measures taken internally. And secondly, with funding from the Welsh Government and the British Academy, it's conducting the first study of health law in Wales, focusing on the way in which this area has diverged from that in the rest of the UK since devolution and the values that might underpin this. Professor Harrington is also Director of the ESRC Doctoral Training Partnership in Wales, a collaboration across 6 universities, which has supported 400 doctoral researchers and 50 postdoctoral fellows over 7 years. He was also recently elected chair of the Socio-Legal Studies Association UK. So we're so grateful to have you here, and thank you very much for agreeing to chair this session, Professor Harrington, and to all the other speakers who are contributing. So I will hand over you to start today's event.
Diolch yn fawr, Olivia. Prynawn da, croeso I bawb. It's a real pleasure to chair this session. I'm very grateful to the Learned Society, to Olivia, Kathy and Barbara for inviting me to chair 3 such interesting papers today on such an extremely timely topic. It couldn't have been better chosen, really, given developments in Wales and in the wider world. As Olivia suggested about my own work, I have a background in working on access to medicines and intellectual property, particularly in the time of the HIV/AIDS crisis, and particularly with a focus on Africa. And so, being as old as I am and having a long memory, I recall struggles about inequalities, social inequalities, global inequalities, in relation to access to antiretroviral medicines in the 1990s and the 2000s. And at the center of those struggles was law, human rights, intellectual property, and policy. And these are things that we're going to be looking at, that our 3 speakers are going to touch on in different ways today, and I'm very much looking forward to that, as we know, and as I'm sure will be addressed in the papers. COVID-19 has come, COVID-19 has posed these very difficult, seemingly difficult questions about justice and law and human rights and access to medicines. There is currently in the World Trade Organization a process which is nearing completion to use the power to waive patent rights of drug companies to meet the present health emergency. There is still a lot of debate about how that is exactly framed. It's a bit like the Northern Ireland Protocol, if you're familiar with that. The devil is in the detail, and it's difficult and not everyone's happy with it. But it is an attempt to address, if I may say so, the scandal that has arisen during COVID-19 of vaccine nationalism in the global north, of countries producing and hoarding vaccines, bypassing the global systems and protecting their own populations, a system which has led to 90% of people in many global north countries being vaccinated, and only 10% of people in the many sub-Saharan African countries, including many healthcare workers. I'm sure we'll hear more about this. Global justice isn't the only dimension here, of course, and our papers are also looking at access to medicines, not just for countries, but for specific groups, for children, for people living with disabilities. These are very significant issues. They're often neglected issues as people focus on the relations between states. And I think they pose for us questions not just of access to medicines, but of drug development. Not just access to the knowledge that's contained in the drugs, but how that knowledge is produced. Is it produced with an eye to all the potential categories of people affected, the different needs of children and people living with disabilities, women's interests and different needs in relation to drugs is not something specifically on the agenda today, but it's another cross-cutting issue that it's worth our while thinking about. So for our speakers, I'm sure they'll be responding to these, and we'll come back to them in our discussion. We could ask three questions. How do social inequalities impact on access to medicines? Secondly, should they impact on access to medicines? And thirdly, what are we going to do about it? What steps are we going to take? And there are a number of areas to look at. There are a number of distinctions to look at. Do we look at human rights and law? Do we use policy and politics? Do we emphasize access? Do we emphasize research? When we're talking about intellectual property, do we see intellectual property as a right or a privilege for the social benefit? These are some of the themes that occur to me looking at the abstracts of these great papers. I'm sure I've spoken for more than long enough now. And so I'd like to move over to introduce our speakers. They'll each speak for 15 minutes, one after the other, and then I will have some response to what they've said, and then we'll open it up for a wider and I hope very productive discussion at the end of that period. So I'll introduce our three speakers today are Dr. Lowri Davies of Swansea University, Rhian Thomas Turner, and Professor Ruth Northway. And I will give a little more introduction to each of them as they start. Our first speaker is Lowri Davies, who's a lecturer in law at Swansea's Hilary Rodham Clinton School of Law. She joined the faculty in 2018. She teaches equity and land law, and her research interests lie within the areas of human rights and intellectual property. Lowri's PhD, completed at Swansea, examined bridging the gap between the distinct regulatory frameworks of international trade law and United Nations human rights law to medicines. So she's an ideal person to start our discussion today. And so I'll hand over to you, Lowri. Thank you.
Thank you. Thank you very much for that introduction. That was very kind. Just going to share my screen with you. Oh, well, good afternoon, everybody. Thank you very much for the invitation to talk to you today about the issues around social inequalities and access to medicines. In particular, my talk today is really going to focus on access to medicines and the UN guiding principles on business and human rights. Because as Professor Harrington has discussed already today, we know that access to essential medicines has been a significant issue for debate in the 21st century. Two key barriers that have been identified in particular for low and middle income countries are issues around affordability of essential medicines, but also the issues around insufficient innovation for medicines that particularly affect individuals in low and middle income countries. And it is well established that states have human rights obligations with regard to health and access to medicines, but the pharmaceutical industry also has a significant role to play. And there are, significant concerns around there being an imbalance between the interests of pharmaceutical companies as private entities, with the social benefits deriving from improved public health through enhanced access to essential medicines. And the UN Guiding Principles on Business and Human Rights, adopted by the UN Human Rights Council, represents a significant step forward in setting out human rights responsibilities of companies. So this presentation today will discuss the human rights obligations of states with regard to the right to health and the guiding principles, and discuss the impact of the guiding principles and discuss some suggestions, on actions by states and the pharmaceutical industry to potentially adjust the current perceived imbalance between public health and private interest for access to medicines. So securing access to medicines for all is a global public health concern. The World Health Organization estimates that nearly 2 billion people do not have access to basic medicines. Many factors can impede access to medicines for the poorest populations in low and middle income countries, but two key and related considerations operate to limit sufficient access. First being the intellectual property rights protection, particularly in the form of patents afforded to pharmaceutical companies. These rights can lead to a monopoly in the market, resulting in less competition and higher prices of medicines, putting them out of reach for many people in lower and middle income countries. Secondly, the physical accessibility of medicines stemming from the lack of research and development of medicines to treat diseases that are prevalent in low and middle income countries, or so-called neglected diseases. Over 1.7 billion people are affected by neglected diseases. For example, sleeping sickness, river blindness, and they can lead to up to around 500,000 deaths annually. A recent GFinder survey reveals that funding for medical research on neglected tropical diseases dropped significantly in 2020, with a 6% decrease in global funding from 2019, marking a continued decline over the course of the last 4 years. So justifications for the monopoly rights that pharmaceutical companies need to recoup the substantial research and development costs involved in creating new medicines. So patent protection acts as an incentive to invest in research and development in commercially valuable medicines, rather than the medicines necessary to treat diseases predominantly in low and middle income countries. These issues can negatively impact on patients' access to medicines and create tensions in international human rights law, which protects the human right to the highest attainable standard of physical and mental health. A human rights-based approach could be taken to examine these issues, as a lack of access to essential medicines impacts healthcare costs and economic growth. Widespread communicable diseases thrive in conditions of poverty and social inequality, and in turn promulgates inequity, poverty, and discrimination. Access to essential medicines has gradually come to be recognised as part of the human right to health. The work of UN human rights bodies has contributed significantly to the normative development of the right to health under Article 12 of the International Covenant on Economic, Social and Cultural Rights. In addition, the right to health is provided for in a number of human rights treaties, including Article 24 of the Convention on the Rights of the Child and Article 25 on the Convention of the Rights of Persons with Disabilities. General Comment 14, issued by the Committee on Economic, Social and Cultural Rights in 2000 to provide guidance on interpreting Article 12, clarifies that availability of affordable essential medicines is a critical component of the right to health, by outlining that access to essential medicines is a core obligation of states. A state has to show that they have made every effort to use all available resources to satisfy those minimum core obligations. States parties' obligations under the Covenant extend to securing essential access to medicines at national level, but also to assisting other states, including low and middle income countries, in accessing medicines. While only states are parties to the human rights treaties and are therefore bound by those obligations, the private sector pharmaceutical industry has a huge impact on availability and accessibility of essential medicines, including on pricing, research and development, and licensing. And in recent years, there has been increasing recognition that private companies have human rights responsibilities. The UN Guiding Principles on Business and Human Rights is the leading framework for understanding that pharmaceutical companies have human rights responsibilities towards access to medicines. As the Guiding Principles have been in existence for 11 years, it is pertinent to assess their impact and their potential to address imbalance between public health and private interest in relation to access to essential medicines. The UN Guiding Principles provides a framework for addressing the issue of human rights harms caused by business enterprises, which is based on 3 central pillars. The first pillar is the state duty to protect against human rights abuses by third parties, including business enterprises. The second is the corporate responsibility to respect human rights and not to interfere with states' fulfillment of their obligations. The third is effective access to remedies. The Guiding Principles were adopted unanimously, which is significant as it reflects states' consensus on their utility. So there is some evidence that the Guiding Principles are influencing policy making at the international and regional levels of governance. For example, the UN Global Compact has directly linked its human rights principles with the Guiding Principles. The EU has strongly supported the Guiding Principles and their implementation at the EU and member state levels. And in the UN Human Rights Treaty body system, for example, the Committee on the Rights of the Child, which monitors the Convention on the Rights of the Child and its protocols, is applying the Guiding Principles in its work. However, there have been some criticisms of the effectiveness of the Guiding Principles. By 2016, only about 40 governments were found to have taken concrete implementation measures. To date, only 26 states have produced a national action plan on business and human rights as part of their responsibility to implement the Guiding Principles. And research shows that many corporations have been slow to implement their responsibility to respect. Almost half of the biggest companies in the world, evaluated by Corporate Human Rights Benchmark in 2020, failed to show any evidence of identifying or mitigating human rights issues in their supply chains. A common criticism of the Guiding Principles is that while they have received a high level of endorsement by stakeholders, the focus on responsibilities of corporations rather than obligations, and the absence of an effective remedy for failing to comply means that the guiding principles do not go far enough to address business conduct which is harmful to human rights. However, an alternative view is that the guiding principles were not intended to create legal obligations as such, or to be a regulatory regime in itself, but rather a platform of guidelines by which stakeholders, including states, may define their own regulatory regimes to promote policy coherence between states' human rights obligations and their actions in relation to business and commercial entities. Therefore, it is appropriate to ask what more states could do to implement the guiding principles more effectively, in particular in relation to the activities of pharmaceutical companies, to seek to address some of the barriers to equitable access to essential medicines globally. A challenge for states is how to effectively address situations where business enterprises do not cooperate with the implementation of the guiding principles. One way could be to develop national law and policy to implement more effective regulation of companies. So states could implement legally binding duties on pharmaceutical companies by introducing mandatory human rights due diligence legislation to promote responsible business practice and avoid and mitigate any human rights impacts they cause or contribute to. For example, where the price of medicines could infringe the right to health. The European Commission and Canada's House of Commons published proposals for mandatory human rights due diligence legislation in February and March 2022, respectively. However, there's little information on specific implications for the pharmaceutical industry, and changes have been called for by civil society groups for an improvement in the effectiveness of some of the proposed measures. However, a potential challenge with this proposal is how promoting research and development in neglected diseases fits into mandatory due diligence frameworks. Another possibility to address some of these issues involve increased funding for the promotion of public and private partnerships and multi-stakeholder initiatives to try to offer a way to address gaps in the availability of medicines for the treatment of neglected diseases. Further steps states could take include greater policy coherence at international level to address essential research and development deficits, which could be explored further. States could also give some more binding force to the responsibilities by implementing legislation that pharmaceutical companies should be required to report on actions they have taken to promote access to medicines and access to medical technologies. And governments should require the disclosure of all costs relating to the production and distribution of medicines, tax benefits, and pricing policies, because this would add a measure of accountability for private companies and may also compel them to justify their expenditure on research and development. In recent decades, it appears that pharmaceutical companies do recognise that in principle, they do have some responsibilities to avoid and mitigate human rights violations caused by their activities. For example, Bayer has adopted a human rights policy that expresses support for the guiding principles, although any disclosures about its human rights impacts lack some detail. Pharmaceutical companies could take reasonable steps to promote the right to access to essential medicines in line with their responsibilities through greater engagement across the sector with initiatives such as the Medicines Patent Pool, which could also contribute to lower costs for patients. Increased technical cooperation and collaboration across the sector, including through technology transfer, could accelerate research and development of medicines for neglected diseases, and greater transparency from pharmaceutical companies on research and development costs and pricing methodologies would help to understand how much the current system for incentivizing innovation is working. The level of endorsement of the guiding principles reflects that there is a desire at the international level for guidance on how to address actions of corporations that harm human rights. Although there has been some acknowledgement of human rights responsibilities of the pharmaceutical industry, such recognition falls short of accountability for human rights infringements. It is unlikely that this industry will accept direct legal liability for violating human rights. Current negotiations over a new UN Treaty on Business and Human Rights includes discussion of a binding human rights obligation on business. And these negotiations are ongoing, with emphasis on developing the guiding principles and building upon these principles. However, agreement on this treaty or such a treaty is not close currently. So while there's much to be gained from heightened scrutiny focused on the business activities of the pharmaceutical industry due to the guiding principles, there is still much work to be done to address barriers to access to medicines, and further actions from the pharmaceutical industry and states in line with their respective human rights responsibilities are still required in order to further enhance equitable access to medicines globally. Thank you.
Thank you very much, Lowri. Thank you for that very concise and very clear presentation, which has a very distinct focus on the business and human rights principles of the UN. A very excellent and useful way to start our discussion. I'm going to introduce our next speaker, but since it's fresh in our minds, I'll throw you this question to think about in the meantime. You say that pharmaceutical companies are reluctant to take on human rights obligations. Should we make them? Should states make them? States can, I guess, do this. States create the patent regime, for example, and they can unmake it. It's been changed. Pharmaceutical companies aren't above claiming human rights themselves. Claiming intellectual property is itself grounded in the covenant on economic, social, and cultural rights. So that's really a political question, but maybe you'll have a think about that. And thank you again. Diolch yn fawr, Lowri.
Diolch, thank you.
So we're passing to our next speaker. And our next speaker is Rhian Thomas Turner. Rhian is Research and Development Lead for the Children's Hospital of Wales and Operational Lead for the Children and Young Adults Research Unit Wales' only clinical research space for children under 18. And I'm impressed and envious that Rhian is not only qualified in the health sciences, she also holds an LLM, a master's degree in the legal aspects of medical practice, and is currently undertaking her PhD at the Hillary Rodham Clinton School of Law in Swansea on children's rights and clinical research. So Rhian is eminently well qualified to discuss children's need for medicines and their development for their special needs. So, croeso Rhian, and over to you.
Great, thank you very much, John. Thanks. I'm just going to share my screen. Okay, great. And I just wanted to say kind of thank you to Lowri, because I think she's kind of started my discussion off quite nicely. So I think there'll be a few kind of emerging themes coming through in these discussions, because I think we are in a very similar space in terms of children and the pharmaceutical industry. Thank you for the introduction, John. I'll say that my kind of journey started within paediatric research when I managed the Children and Young People's Research Network, which was then Welsh government funded network. And I think at that point, it became quite evident really that children were not accessing innovation in the same way as a lot of adult counterparts. So it was at that point it kind of really interest around policy drivers, and then I worked with a paediatrician Elspeth Webb, who was very felt that children's rights should come into this conversation. So that kind of started this conversation off for me. So I'm going to really be kind of concentrating on children, not necessarily from any particular area, because these things impact children in both high income and low middle income countries. It just seems there's just very different impacts in those two countries, but I have two areas, but I am going to kind of concentrate on children as a whole as part of this session. And So I've done quite a lot of work with a colleague at the observatory in Swansea University, Rhian, because we started a lot of our discussions around the impact of the lack of research infrastructure in Wales and the impact on children. So this is part of one of the papers we did during COVID, where we were looking really at the impact of, impact of being a child, really. So it was, this kind of sums it up, where children are prevented from having equal access, equal status, equal access to resource, equal access to decision making, or to exercise rights in an equal manner, simply because they belong to a social group categorized as children. And I do think that this has become caused probably quite a lot of the issues along the way, is this concept of the child and a child's vulnerability. And there's no point kind of not addressing it. Children are dying because there is a lack of suitable medication available for a lot of their conditions. But this has also been countered with this long-held belief that children should be protected from participating in clinical research. And then we're kind of left with the situation of how do we really address these issues from both sides, because I think we are very much looking at this being not just a clinical research issue, but a perceptions and a policy and ethics. Everything kind of really does need to come together on this subject. Perceptions of vulnerability, they're deep rooted, not just with children, but with other groups of people, and they are deep rooted in terms of coming back to the Nuremberg trials, Nuremberg Code, and what we find is when things like this happen, then we tend to become quite paternalistic and very much put walls up to protect people. There was debates in the 1970s, and with Ramsey coming forward and saying that he felt that children shouldn't be participating in research unless there's a grave illness. But then I think what we find then is, whilst we're protecting, we're also failing to see what the collateral damage is in these situations. Very much as we've seen with COVID, we've been protecting people's health without the physical health with regards to COVID, without really considering what the massive impact has been on the paediatric population of lockdowns and the mental health implications, but also the long-term implications of lack of access to schools, to education, and what that will do for these children 30, 40 years down the line, when their educational attainment hasn't hit the levels that it could have done. So kind of coming back then to paediatrics, and this concept of vulnerability, it's still very much there, but I think we have started to see some changes over the last 15 years, probably in Europe, around conversations of this does need to change, that we are, whilst needing to protect children who do participate in research, but we do also need to open up these opportunities for them to participate and to also have medication and medicines developed for their needs, their specific needs. So this is where I suppose law comes in as part of this conversation. In 2007, the paediatric regulation came into force in Europe. The UK is still very much working towards this paediatric regulation currently, although I think there are some discussions, because it is going through a series of changes at the moment, and I think the UK is looking at whether those changes work for it. So the paediatric regulation was introduced to try and stimulate the development of drugs for children from 0 to 17, and I think some of this will, kind of highlighted with Lowri's work, is that we need some incentive to get the pharmaceutical companies to do this, because they were doing it, because out of the kindness of their hearts, they were having to do this because they were being offered additional money to do this research. This kind of conversation continued, and it started long before 2007 in Europe, but much more before that in the US as well. I think in the US, which is I suppose quite surprising in terms of it hasn't ratified the United Nations Convention on the Rights of the Child, but it was very much advanced in its legislation around paediatric medicines development, and so it started in the 90s in the US. Then in 2012, the Royal College of Paediatrics and Child Health released its report, Turning the Tide, which is very much based around paediatric research. and just said, you know, we need access to medicines for children that do fit their physiological, biological differences. This is very evident in things like pediatric cancers, where we talk in adult cancers very much about prevention, about what we can do with our lifestyles to stop the children don't get cancer because of, you know, lifestyle choices. You know, a baby isn't a 2 hasn't caused its cancer. These are genetic, they're different kinds of cancers, so we need to be looking at these differently. And then in 2015, the Nuffield Council on Bioethics released its report on children and clinical research, which was an excellent report. Didn't mention children's rights, but very much had this basis of rights, vulnerability, and trying to change the emphasis on children as vulnerable people, but, you know, to work with them, to gave kind of pointers on working with children on how you can bring them into these conversations to make them less vulnerable, because they're part of the decision-making process. And it was the chair of the Working Party at that point that said that the time's come to protect children and young people through and not from research. So moving on, really, how can we use these international rights frameworks to support children's access to medicines, because it is very much an access question. If you and I think I've got on the WHO, it is very much about access to medicines and research. So research can support access, but access to appropriate medicines, access to medicines that actually are developed for the condition. And the WHO, so we've got the WHO definition of unmet medical needs, which I'm currently working on with regards to the PhD I'm doing. And I've heard these discussed quite a few times in different paediatric settings around what does unmet needs, what does access mean? And it does mean a kind of few different things, where something has become ineffective due to resistance. And I suppose this is where we're going to be looking more on antibiotic use. The delivery mechanism or formulation is inappropriate, and we see this a lot of the time in paediatric, especially in neonatology, where we don't have a suppository, for example, that is made for that population, so it gets cut down the middle and hope for the best in terms of dosing and things like that. Or you've got to crush tablets and put them in water. That's not what they're made to do. You don't know, so you don't know if it remains effective. So I think it's all of these things that happen to pediatric medicines because they're not developed correctly, or they're not developed in those formulations with the liquid suspensions and things like that, because that costs money to do. And it doesn't always happen if pharmaceutical companies know they will be used off-label or off-license. And also then where it's not sufficiently effective, where lack of basic knowledge, or and I suppose coming back to what Larry's talking about, lack of financial incentive, that paediatric medicines are seen as market failures because they are highly unlikely to make money for the pharmaceutical industry. So if we can kind of come back to that point, it's the fact that these paediatric markets are small markets, and they are there isn't the money behind it really to stimulate interest. We also have, kind of going back one step further, especially in environments like neonatology, is that we don't actually have any of the basic science to help us to understand what those conditions are in these populations. And this is more around conditions of prematurity, as we're able to keep children alive from a much earlier gestation, much earlier in terms of prematurity. We're not really understanding what it is that what is happening, what are the potential kind of outcomes for these children. So this will come obviously in time, but we don't have that basic knowledge because it isn't invested in as a priority, as a research priority. So again, I think probably coming back to with Lowri, we're talking about very much similar conventions here, the International Covenant on Economic, Social and Cultural Rights. And a topic for me that I'm very much honing in on is what can the United Nations Convention on the Rights of the Child do in this area? So just a kind of a basic overview really of the relevant international law in this area, or as I perceive it to be anyway. And that is your guiding principles within the UNCRC of non-discrimination, best interests, right to life, survival and development, and the right to kind of an opinion, and the right to have that opinion taken into account. Evolving capacities, I think, is very relevant within the research environment. I think this comes back to the whole conversation around vulnerability, because if you're supporting children to make decisions and to participate, then that kind of vulnerability argument really falls down slightly. But also then, as Lowri mentioned previously, Article 24 on the right to health, General Comment 16 on the impact of business dealings on the rights of children, and much more recently, I think we're looking at the rights of children's rights in the digital environment as healthcare moves much more into this digital environment, and clinical trials are potentially moving into much more of a digital environment where we can potentially use different models to make things work better for children. But a lot of these general comments don't hone in on health, so I think this is where we need to maybe have wider conversations. And then in terms of the International Covenant on Economic, Cultural and Social Rights, which we've, myself and Rhian Croak have had a lot of discussions around because of the impact of, so we had an issue around research infrastructure funding going into clinical research in paediatrics in Wales, where it was pretty much non-existent. It's increasing now, but we went through a discussion, or we had to give evidence to the Children's Committee on the impact of the Children's Rights Measure in Wales before we could have any of these real discussions at Welsh Government level, because it's really hard to get people to listen, to get government to listen on this. So I won't kind of go into this too much, but really, we're talking about the right to health here, Article 24 of the UNCRC. I think it's really important to look at the wording in it within this article. We are looking at the right to curative services as well, and part of that curative service is this access to appropriate medicines. If we come back to paediatric oncology, paediatric cancers, we have some cancers that just, one in particular, which is a brainstem cancer in children, which has no treatment. There is nothing. It is they would be palliated straight away, and within 7 months we'd expect to lose that child. Now, there's so few children with this that it's not seen, again, as something that you would pharmaceutical companies wish to spend time or money on. But there are, I think what's quite interesting that's coming up in this area is a lot of kind of different collaborations that are happening with science and charities and things that kind of are bringing this forward, but I suppose de-risking it for the pharmaceutical industry. Probably something that John will know more about than me, but within General Comment number 3 with the UNCRC, it does very much specifically talk about research in the HIV/AIDS setting, but very much saying that we do need research that brings treatments that are there for children, and therefore they're able to access this appropriate treatment. General Comment 16 again then comes back to the impact of business and the business on the rights of children, and I think this is just kind of coming back to some of Lowri's argument. This is quite a long. This will be a long drawn out argument, I think, trying to get pharmaceutical companies to really take on board what their obligations are and how states will do that. And I think it's quite interesting at the moment, some of the discussions around changing the corporate legislation in the UK and whether that would potentially have an impact on this. And then finally coming into kind of this Article 15(1)(b), this right to science, or the right to benefit from scientific advancement. And this is something that I find quite interesting in terms of trying to build a research infrastructure. And that research infrastructure is essential for children to access these trials and to access these medicines. And I think coming back on some of these points, children will only be able to access some of these medicines because they are they're still experimental. They'll only be able to access them through clinical trials. This is kind of another component of that. Just conscious of time. So I'm just really coming into this discussion then, really, what can we do to change things? And I think from my perspective, I've worked in research longer than I've been kind of involved in children's rights, but we do very much concentrate on research ethics. And that's a circular, I think that can be more of a circular argument. I think how do we bring in law to have these discussions? How do we show that these are legal rights of children? This is not charity, this is not, us doing them a favor, these are their legal rights, and how do we as kind of grown-ups to support these children in terms of exerting those rights and being able to give them, to help them find information that allows them to have these discussions. How do we support them? And I think from our perspective then, we do a lot of clinical trials, we do a lot of pharmaceutical company clinical trials, because that for us is a really important way of some of these children accessing these medications. We tend to make decisions around which ones we do, depending on what the unmet need is and whether or not we have patients who will may directly benefit from this medication. But what we do find is clinical trials are very much developed for the adult population. So we really need to find a way of having these discussions with pharmaceutical companies to say, that's not actually okay that you bring a child in 2 days running, they need to go to school, or, how do we get people thinking differently? And then back to this kind of whole concept around using now technology. Real world data is a big deal within clinical trials at the moment, and not just trials, but pharmaceutical companies are really kind of jumping onto that. But how do we protect children within this setting, but also how do we then bring them into this setting so they are kind of child stakeholders in this environment as well? So that's it from me for now. So yeah, thank you very much.
Rhian. That's really great stuff. Thank you very much. And I love the way it built on what Lowri was speaking to us, elaborating and picking up on some of the human rights and legal materials, and talking back to the question of business responsibility, business contribution. So I can see the continuities emerging there, and I hope you'll be speaking to each other in our discussion. As I did with Lowri, I'm going to throw a question out to you. It's part based on your paper and part based on your background in research with and on children. You make a great case for human rights and the relevance and how it's covering it. What about the Welsh dimension? Is there greater possibility for integrating human rights and having it actually achieve something in this context in Wales than in other contexts? For various reasons, devolution, an administration and system that, I don't want to get too controversial, is perhaps more human rights friendly than other administrations in the rest of this island. I said it. Yeah, I'd be really interested to hear about that combination from you. So thank you again, Rhian, for that. I will move to introduce our third speaker. I'm delighted to have her. That's Professor Ruth Northway, OB and Fellow of the Learned Society of Wales. Delighted to have Ruth. Ruth is Professor of Learning Disability Nursing at the University of South Wales, has been a learning disability nurse for over 40 years. And prior to working in nurse education, supported people with learning disabilities in residential and community settings. Her research interests focus on this. She's a member of the Welsh Government Learning Disability Advisory Group, past chair of the Royal College of Nursing Research Society, and co-chairs the Ethics Special Interest Research Group of the International Association for the Scientific Study of Intellectual and Developmental Disabilities. So a formidable track record and background, and great to have you here, Ruth. I'll pass to you for our last presentation, Jill.
Okay, thank you for that introduction, and thank you to the Learned Society for inviting me to give this presentation. I'm going to try and cross my fingers now and hope that my share screen works. Brilliant. Okay, so as per the introduction, I work as a professor in learning disability nursing. What I will say within this presentation, you'll see that I've used both the term learning disability and intellectual disability because in the UK, we tend to refer to people with an intellectual disability. Elsewhere in the world, they tend to refer to intellectual disability. So it gets a bit confusing, but please accept I'm using those terms interchangeably. My presentation will build upon the previous ones. You'll see some common themes coming through. But obviously, I'm taking a slightly different approach because I'm looking very much at a very specific minority group within society. So if I can get this to move on. Okay, so as a starting point, I mean, we've already alluded to the fact that there is the UN Convention on the Rights of Persons with Disabilities. And Article 25 refers to health. It talks about persons with disabilities having the right to the enjoyment of the highest attainable standard of health without discrimination on the basis of disability. And it talks about the range, the quality, providing care, preventing discrimination on the basis of disability. So obviously, you know, access to medicines comes very much within this remit. I think what is interesting when you look at the wording here, it doesn't talk about the right to health. It talks about the right to enjoy the highest attainable standard of health, accepting that probably everybody's health potential is different, particularly for some people who are disabled, people with learning disabilities. They may have particular health conditions which make it difficult for them perhaps to do certain things. They have their day-to-day experiences, but actually, you know, if we work and we look at things like medication and other interventions, we can help them attain their highest standard of health, which may be different when you compare it to other people within the sort of community, but it is the highest that they can obtain. So that's really what we're working towards. So what do we know about the health of people with learning disabilities? What I have to say here is, firstly, I suppose a caveat that most of the work which we have, and we have a growing body of evidence around the health of people with learning disabilities, comes from high income countries. You know, there are significant gaps in relation to people from low and middle income countries, but we would assume that, you know, at least the same inequalities are there. They may be even more significant, perhaps, however, within those contexts. So people with intellectual disabilities, learning disabilities, will experience the same range of health problems as the wider population, but they might sort of vary in terms of frequency and presentation. We've got international evidence that, however, many people with learning disabilities experience health inequalities or health disparities. So when you compare patterns of health within this particular population, they are different to that of the wider population. One of the differences is that they often experience what we call multimorbidity. So they're often experiencing more than one condition. So it can sometimes be 6, 7, or 8. And what that, of course, brings with it is usually multiple medication. And the interactions that can happen between those different sort of medications. And also, compared to the wider population, this multi-morbidity tends to happen at an earlier age. Overall, life expectancy of people with learning disabilities is increasing, but they continue to experience premature and avoidable deaths. So, you know, obviously there are things there which we need to focus on. And, you know, this study by Lowri et al., it was a systematic review. On average, the studies which we have say that people with learning disabilities die 20 years earlier than their non-disabled peers. And that's often due to avoidable causes. There's also inequalities, I would have to say, within the population, because the gap for women with learning disabilities is greater than that for men. I want to just raise, I suppose, another thing to consider at the very beginning. Are we talking about inequality or are we talking about inequity? And going back to the work of Whitehead in 1991, she would argue that some differences are unavoidable. They just are, and they would be inequalities. But where differences are amenable to change and they have a negative impact on people, and those differences are not addressed, then they're unjust, and we're talking about inequities. So if you give an example here, you know, we would expect people with learning disabilities as a population to perhaps have higher rates of taking anti-epileptic drugs because there's a higher incidence of epilepsy. So you would expect that is an inequality that's there. However, if there were a new drug that came out, anti-epileptic medication, and people with learning disabilities were denied access to that, maybe it's very expensive or what have you, and they have difficulty in getting access to it compared to their peers, then you would argue that perhaps that is an inequity. It's not inevitable, it's something which can and perhaps should be looked at. And we're talking here about some of obviously the ethical principles about not doing harm and ensuring justice to people. I'm going to focus on 3 different sort of areas here. And the first one, you might think, well, you know, we're talking about access to medication and why she put this in. But I want to highlight that sometimes access, there can be too much access, and that in itself can be an inequality. So people may be familiar with psychotropic medications. Those are the medications which are used to treat mental health problems and epilepsy. Obviously required by some people and are very effective for a lot of people. However, for people with learning disabilities, what we find is sometimes they're actually prescribed for people whose behaviour is perceived by other people perhaps as challenging, but they don't necessarily have a diagnosed mental health problem. It might also be that the medication is given to them, you know, rather than trying other interventions, which perhaps are looking at environmental interventions or psychological interventions. And, you know, it's often the case for people with learning disabilities, and they've got some figures here. Public Health England estimating that, you know, 30,000 to 35,000 people with learning disabilities were taking that type of medication without actually having the health conditions for which it's usually prescribed. So on the sort of right of the screen, you'll see there these things, Stomp and Stamp. You're probably thinking, what on earth are they? But these are initiatives which have been developed to try and reduce that difference, that disparity, to try and encourage more frequent review of medications, to try and make sure that where people are accessing this type of medication, it is appropriate for their needs, rather than just being used to sedate people without looking maybe at what is the underlying cause of behaviours that challenge. I'm going to sort of pick up here on the issue which Rhian sort of has talked to as well, about access to clinical trials. And obviously, I mean, there are challenges perhaps in clinical trials specifically for people with intellectual disabilities, because you've got a very small group of people, you know, so when you're looking to try and get appropriate sizing, it can be difficulties recruitment, etc. But what I'm talking about here is more access to participation in broader clinical trials, which might be looking at medications. And I have to sort of say at the very beginning, I'm not arguing here for people with learning disabilities just to be included, because obviously if we look at history, we do know that people with learning disabilities have been harmed, have been coerced, have been exploited in the context of research. You know, if you go back to, we've talked earlier, I think Rhian mentioned the Nuremberg trials, you know, and that was partly because people with learning disabilities were experimented on within the concentration camps within the Second World War. However, you know, if some of you may be familiar with the Willowbrook case, that was only going on in sort of 1971, where children with intellectual disabilities, learning disabilities, were deliberately infected with hepatitis to try and develop a vaccine against that. And time doesn't allow me to go into all this sort of the arguments for and against that, because some of those arguments are still going on. But you know, even when we had sort of Nuremberg Code, we had principles and things like that, things were still happening, and there was evidence of coercion there. So as a response to that, people with learning disabilities are usually classed as vulnerable subjects in research. And if you look at a lot of trials, you will often see, when it's the section on ethics, you know, an exclusion criteria will be unable to consent. And, you know, it's really important to think through what some of the consequences of that are. Victoria Shepherd and colleagues in Cardiff have done quite a lot of work around trying to support the inclusion within research of people who maybe are lacking capacity or have reduced capacity. And they talk about this supposed sort of protection through exclusion. And I suppose my sort of argument is, I think people, yes, there is the potential for harm to be caused by inclusion, but there are also harms which are caused by exclusion. You know, if people's views and experiences are not reflected within research, you know, to what extent can we say that research can be generalized to the wider population? And Feldman and colleagues have looked at this and sort of argued that given the different health profile of people with learning disabilities, we can't assume that they will always respond in the same way to certain medical treatments, including medicines. You know, if somebody does have a particular pattern of multimorbidity, you know, adding an additional medication in may be particularly challenging. It may be that people's needs in terms of how they take the medication, for example, you know, if you've got somebody, some dysphagia is a common problem for some people with learning disabilities. It might be that, you know, we need it in a different format. So it's things like that. And they're talking about how can an evidence base be developed that appropriately reflects their needs if they're constantly excluded from taking part in research. But also it might mean in some circumstances they're denied access to new and innovative treatments because they're only available if you're in a trial. And if you're automatically excluded because you're perceived as not being able to consent, you know, there's a disparity there. If you look at the study undertaken by Feldman and al, they looked at 300 trials which were published, you know, obviously within the period of time stated there. And what they found was only 6 clearly included people with a learning disability, so only 2%. When they looked at how the research was undertaken, over 90% of the studies were designed in ways that would automatically exclude people with learning disabilities. So they were using very, I suppose, traditional research approaches, which either the way in which information was given or the way in which things were explained to people, or the requirements of, you know, filling in self-completion questionnaires, for example, could pose a barrier for somebody with a learning disability. But they also concluded that when you looked at those studies, they estimated that probably about 70% of them, if they had changed the way in which the research was undertaken, people with learning disabilities could have been included. So it's something, if you go back to what I said earlier about sort of inequality versus inequity, probably this difference is not inevitable, it's something which could and should be changed. Obviously, we talked earlier about, I think Rhian again mentioned, how do we bring the law into the discussions? Because often it's, you know, we focus on the ethics, but, you know, we do have legal frameworks which we can use to help this. Mental Capacity Act specifically says, you know, decision making has to be decision specific. So when you're looking at somebody's capacity, you can't just look at somebody and say they are unable to give consent. You have to be looking at, can they consent to participate in X or Y? And it also recognizes that, you know, capacity is not fixed. There are things which we can do which will enable people. So the way in which we present information, for example, you know, the difference between a participant information sheet, which is, you know, in very, very small print, complex language going on over 4 or 5 pages, is very different to getting those key principles put in very clear, simple language, supported perhaps by pictures, which will also help people to understand, people explaining it in particular ways, giving people time to reflect. So there are things which we can do which will facilitate people's capacity to make those decisions. But also in the Mental Capacity Act, there is provision for those who lack capacity to participate in research, you know, using a consultee. You know, if somebody, as long as somebody assents, they don't object to that. If there's certain conditions are met, there is that provision, but I don't often see that being used. And again, I think some of the work that's been undertaken by Victoria Shepherd and colleagues, that sort of provision for a consultee is not always explicit within that. To think about how this sort of impacts in terms of practice, and where there may be some value judgments perhaps being made about access to medication. I'm going to use the example of COVID. And what we do know from the health profile of people with learning disabilities is that respiratory disease is the most common cause of death. So we know that. We're then faced with a pandemic where it's a respiratory infection primarily. And yet, you know, people with learning disabilities were not prioritized for vaccination at the beginning. You know, there was the prioritization on age, but remember what I said about, you know, people with learning disabilities dying earlier, they probably would not have been in the same numbers in the higher, sort of higher age groups. Not just peculiar to this country, it's happened elsewhere. So in the US, people with intellectual disabilities were absent from the phase 1 tiered guidelines. And an argument had to be presented for their prioritization. Again, in the UK, people with learning disabilities were not initially prioritised for COVID-19 vaccines. It was amended in February 2021. However, a lot of that only happened after campaigning by, you know, people coming together, a lot of sort of the third sector organisations, families, and I think actually, I can't remember if it's Jo Wiley, the radio DJ, her sister has learning disabilities, and there was a high profile case which went into the public domain. Her sister had not been prioritised, it hit the news, and then we started to see some change. So, you know, you start to think about, okay, what value judgments are going on about the lives of people with learning disabilities and the access which they should have to some of these medicines. So, you know, I've only been able in the time that we've got to highlight a few key issues, but I wanted to try and look at it from some different perspectives. I think what you can probably see, hopefully, is that both inequalities and inequities exist. And they can take many different forms, whether that's overprescribing, whether it's a lack of prescribing, or whether it's about even earlier in this sort of process of medicine's development. And that people with learning disabilities do not appear to be receiving access to medicine that supports their right to the highest attainable standard of health, if you go back to the UN sort of declaration, or convention, sorry. So I think, you know, hopefully I've pulled through some of the issues from the other presenters, and you can see where some of that happens. And I think there's probably a lot of other things I could have said about this area, but time prevents it. So that's me done.
Thank you very much, Ruth. And I'm sure we will come to some of the issues that you mentioned in the discussion. But thank you again, as with the other speakers, for a very concise presentation that really addresses the theme of this workshop and the title of the workshop on social inequalities and access to medicines. I was particularly interested in the kind of play between under-researched and over-medicated concepts, which I hadn't, the second one certainly I hadn't thought a lot about, in a way you added that to the foregoing discussions about lack of access, lack of research, and developed it in this specific context. I hit everyone with a question, so I'll do the same to you. The other distinction, which is very important, I think, for your papers between inequities and inequalities, and you spent quite a bit of time talking about it. I guess it's a movable line. So is it part of the project, the Human Rights Project, to move the line towards inequalities, to see more things as inequities? And would that influence the concept of attainable, which you take from the Convention on the Rights of People with Disabilities, which again is an interesting usage, specific not to different countries, as it is seen, for example, in the International Covenant on Economic, Social, Cultural Rights, but specific to different types of patients. So yeah, that line between inequity and inequality, how is it moved? Should it be moved? I'll let you with that one. In fact, if you want to reply now, and then I'll come back to the other, to Rhian and Lowri, and see if they've got answers to what I said earlier, just by way of getting our discussion going. So over to you.
I'm happy to come back in. I think it should be a movable line, because I think if we take the fact that, you know, something is unjust, we should be trying to change that. But I think we probably do need to do much more about discussing the difference between inequality and inequity, because I think sometimes they're used interchangeably. And I think, you know, trying to frame that discussion much more around inequity and what we can do to change that, framing it as an issue of rights, I think is helpful. You know, if you just take the thing around sort of inequity of access to trials, you know, we know that there is inequity of access. You know, I've said about, you know, people with learning disability, Rhian said it about children, but we also know that there are things which could and should be done to change that. So I think it is about, yes, opening up that sort of discussion, trying to frame it in terms of inequity, trying to give some of those solutions when we know that there are changes, and making sure that people are aware of that. So for example, you know, for me, that the whole thing about access to research, not just in terms of medicines, but more generally for people with learning disabilities, is that we don't always, as researchers, we don't always think some of these things through. You know, we're not always trained to think about ways of how do we include people. You know, we should be asking questions about who isn't included when we're looking at, you know, we talk about inclusion, but who are we excluding? And that requires us, I think, as researchers to think differently. You know, we spend a lot of time teaching people about how to do surveys, how to do statistical tests and things like that. We don't always spend time saying, how can you make information accessible to people so that you can do it? How can you alter the way in which you're doing your survey so it's more inclusive to people? So I think it probably requires action at a number of different levels, but I think we should be seeing it as a movable line, and we should be pushing for that movement.
Thank you, Ruth. That's very helpful. Further clarification for me at least, but I think for everyone. I'll go back to our speaker, the other two speakers, on the questions I asked them. I'll go to Lowri first because she was our first speaker. And this question about maybe having a more proactive approach, but even aggressive towards, or at least normative approach, I suppose, towards businesses in this context. Do you think that that's a useful approach, a necessary approach? How does it fit into your analysis?
Yeah, I think one of the key things that we've seen in how the guiding principles have been implemented so far is that there's an emphasis on the responsibilities of businesses and by extension pharmaceutical companies, but there isn't that transference to the question of accountability. And I think that's a key thing that we need to delve more into and explore further. How do we hold these companies accountable for human rights infringements? Yeah, as you talked about earlier with regard to kind of companies and them trying to assert that they have human rights and intellectual property, they have an awareness of human rights in that sense. But you know, as the UN human rights bodies have recognised, in terms of thinking about IP as a right, it's a property right. It's seen as a social product with a social function. And if, I think it was Paul Hunt, the former UN special rapporteur, talked about the fact that if these companies are taking on the responsibility, if you like, of developing products, developing medicines to address social issues, address social inequalities, and medicine to create medicines, then they've got a responsibility in terms of ensuring that those are available and accessible to the market, the patients that need them. And I think, you know, in terms of thinking about the perspective of pharmaceutical companies and thinking about capitalist issues and questions around you know, free market and that sort of thing. If we're looking at patients, if we're looking at the range of patients that we talked about today, whether that be children or persons with disabilities or persons in low and middle income countries, if they require essential medicines, then they're a captive market. They're not a willing market, in the sense that if the medicines are essential to them, then they're necessary. They're necessary for their well-being, possibly for their life as well. So I think that there is a need to explore further the accountability question. I think it depends on the political will of the governments. I think, as you said, it's a political issue as well, and I think we're aware of the pharmaceutical industry's tendency to lobby governments and the influence that they can have. But you know, as Rhian mentioned, it's interesting to think about the corporate social responsibility legislation, for example, in the UK, how that might be extended, how that could be looked at in terms of continuing to explore the responsibilities in terms of human rights in respect to pharmaceutical companies, And I think, as all the speakers have talked about, the issue of incentivising innovation is a really important one that we need to explore. So I think continuing the discussion of accountability and thinking about how we can link that into the question of innovation, the question of how we can further incentivise or de-link costs from research and development, finding different strategies for incentivising innovation, I think are all really important. I know that we've seen some examples, I think, in Latin America. I think of an example where health litigation, rights to health have been litigated in domestic courts, and for individuals that has had impact on an individual basis. But I think that that's not really enough. We need to continue the discussion. We need to go further, and we need to explore how we can make more binding obligations, how we can look at this issue of accountability and take that further. And the guiding principles can perhaps form further discussion on this, but the third pillar, remedy, is also important. It's very difficult. I think that there are limited ways in which an individual could seek a remedy from a pharmaceutical company for potential human rights infringement. So I think these issues require further exploration, but I do think that it is an important question. I think we do need to think about this in terms of pushing forward a human rights-based discussion on access to medicines.
Thanks very much, Lowri. That's a really very full answer and very helpful. My own point on that, a response would be something you've said in your paper, is it still seems to bear out the key role of the state as regulator of companies, as creator of the company form, as creator of patent monopolies. And then different types of states in the global north and south, the states where the companies are based, do they owe duties? You may come back, so it's as you know better than I, the duty on states to protect the right to health by regulating private actors. And that's also something that Paul Hunt mentioned. So thanks very much for that, Lowri. I'm sure we'll come back. I'm just trying to cash in on my earlier questions. So Rhian, you're the last one. I asked you about Wales and human rights. We're talking about the state. In Wales, we're talking about kind of sub-state for these purposes, but with devolution, particularly devolution of health and the kind of institutions you've been working for and leading. Is there greater scope for that here in Wales? Can we be pioneers and pilots? Is it being achieved already?
I think, yeah, thank you. And I'm going to respond to Lowri later as well, because there's some really interesting points that she's made there. But yeah, I think technically in Wales, we have that ability to go one step further, because we do have the children's rights measure, and we do have ministers must pay due regard to the UNCRC when they are making decisions. So that is kind of great in theory, and I do feel that we have that kind of fundamental basis that we could potentially be pushing forward on these questions and forward on making these changes. I think that we do have a few hurdles that we'd need to get through in order to do that. Firstly, in the kind of knowledge around the obligations of ministers within the UN, within the children's rights measure. We did find that when we were giving this evidence, and when we were kind of exploring and speaking to some fairly kind of high-ranking individuals within the Welsh government infrastructure, leading civil servants in these areas, there's still a lot of lack of understanding around what their obligations are within the UNCRC, and the children's rights assessments that they're meant to do as part of budget discussions and things. So I think we have potential. I think we've got the bones to do it. Then I suppose it's where we come in terms of making policy on that level. So the MHRA has its paediatric committee now. That's because we've left Europe and left the paediatric committee as part of the European Medicines Agency and become kind of the UK MHRA has taken that. But those decisions are made on an all UK level. So I wonder how much power Wales has to kind of really break free in terms of being able to do kind of regulations in this area and stimulate that within the pharmaceutical industry. I think maybe Wales and Scotland together might have more of a chance. I don't think England is looking in that area, in that space, in terms of using human rights to drive these discussions, these legislation changes. I think Wales and Scotland are. Scotland is going one step further than Wales and trying to incorporate the UN CRC into kind of more of a human rights type of, Human Rights Act. So I think there is that potential, but I think if we were to move forward with changing the paediatric regulation for the UK to have its own version of the paediatric regulation, if the devolved nations could have more of a say in this, then I do think we could have a rights-based approach to development and to access. But as Lowri said, we've got huge structures to change. We've got conversations around incentives and innovation, and I think it would be great if Wales could influence that, but I think it would need to be a UK move, I suppose, towards those discussions in order for that to happen.
Thank you very much, Rhian. I suppose they very much value your perspective as a practitioner and leader within the sector, as well as a scholar in this area. One thing that flashes into my head in some of the things you're saying is, the UK Wales issue is also one related to the internal market, the UK internal market, which the Act restrictions in different parts of the UK, which might be impediments to that market. And that may be something that we have to think through in Wales and in Scotland and Northern Ireland, indeed, the extent to which health values and human rights values can still be promoted while staying within the corners of that binding legislation. So thank you all very much for that. I do invite you all to think about questions for each other, and I know you've been speaking to each other in a way in the papers and the discussion. I hope we can come back to that. But in fairness to our audience, I've had a couple of questions which I would like to pick up and put to you. Barbara, would you like to ask your question? I think that'll be more interesting than me just reading it out with my boring voice. Barbara.
Thank you. Thanks, Joan, and thanks to everyone in the panel. It was a very, very interesting and informative presentation. And my question has to do with how, health models and treatments within countries really facilitate the uptake of these UN principles. To what extent do we know, if that's one of the reasons why these countries don't follow the guidelines? And I guess this question will be first to Lowri, if that's okay.
Hi, Barbara, thank you. Yeah, I think that, some of the reasons why some countries have not adopted the guiding principles, or they've been slow to implement them. A couple of themes have come out in terms of, firstly, a lack of awareness or a lack of understanding of what it is that is expected in terms of translating from international level into domestic legislation or domestic policy. And I suppose linked to that is the political will to do so as well. Which is a key issue, I think. A lot of the issues that we talked about today, I think, relate to political issues as well, in terms of the development of health policy and so forth. I think in terms of looking at the guiding principles in the context of health in countries, then I think another criticism of the guiding principles we've seen is that it tends to be seen as a negative obligation, in that companies shouldn't be making human rights issues worse. But I think that, from the discussions we've had today, we can see that pharmaceutical companies have also responsibilities. They have positive impacts to make on the issues that we've looked at today, particular access to medicines and the different specific issues that each of the speakers have talked about. one of the things that the guiding principles emphasize in terms of responsibilities is kind of embedding that within the business practices. So I think more transparency around the policy, the business's policy in terms of how they are addressing issues in terms of human rights. I think in terms of the human rights practices, I think there could be more transparency about that. I think also issues around expenditure are another key issue. Financing of health systems, health expenditure, the issue around public funding and how that is facilitating research and development as well, is something that I think we've seen a lot talked about, particularly in relation to COVID vaccines. And I think one of the things that has come out of the discussion around vaccine nationalism in the countries in the global north that we've seen through the COVID pandemic is this question of how do we, I guess, tie in the obligations, or could we tie in the obligations that pharmaceutical companies have in terms of human rights to receiving the public funding that they have? Because we've seen with we've seen much public funding being contributed towards the development of research and development in that context, but there wasn't really any kind of linkage to how that vaccine, as it was developed, was then going to be distributed. There's no kind of issue around the property rights in that vaccine and the responsibilities, the accountability in terms of public funding being contributed and what the outcomes are for the individuals. So I think there are several issues there that we need to explore further in terms of how we can link up the guiding principles to our health models in countries. And obviously different countries have different specific issues within their health systems as well, which again is a complicated issue because it's not a one size fits all situation, but I think it's definitely something we need to explore further in looking at how we can more closely draw in the guiding principles into pharmaceutical industry and in our healthcare systems going forward.
Thank you so much for your response. And I was just thinking about the case of Mexico as well, because right now, how to be accountable for these politicians who they underspend in the public health system. And then I could see how complex the model is in terms of it's not just the companies but also the politicians and the state itself, that is not aligning to those principles to have basic access to medicines. Thank you so much for responding to my question.
Thank you, Barbara. I mean, if I might chip in briefly on that point, Lowri, I mean, another strategy, another way in which the principles might come in is through investors. So ESG investing is now quite a big thing, isn't it? Environmental, social and governance focused investing, often with relation to climate change, but this is also an area, and it may be that's something that plays out, and I'm sure you're thinking about that. I'll move to our next question, which is from Rafiq El-Mansi. Rafiq, would you like to come in now?
Yeah, can you hear me?
Yeah, very well, thank you.
So I'm teaching in Grinder University in Wrexham, and my focus in research is in design and healthcare and empowering patients through self-administered intervention. So when you're talking about the medicine, about the equality in access to medicine, we are not in African countries, but all around the world, we are faced with a challenging problem in terms of costs, increasing costs, and limited resources. So there is several health technology that aims to empower patients through patient administered intervention, diagnostics, and treatment. So how do you see this as a solution for the problem of access to medicine?
Rafiq, would you like anyone in particular to pick that up, or will we leave it to our three panelists?
I would say to leave it.
Okay. Thanks for the question, Rafiq. Rhian, did you want to come in?
Yeah, I was going to say I'm currently working on a secondment basis 2 days a week with a health technology company based in Wrexham, Aparito. So yeah, I've just trying to really explore this. So I think really trying to get my head around how technology can support. And I do think we've got a huge number of opportunities if we're able to kind of roll out much more access to the kind of technology to record patient-reported outcomes, to understand really what it is that patients are dealing with, the actual proper endpoints. And I think then if you have that information, if you have that data, then you're not wasting quite so much resource in developing medicines in areas that probably are not essential, or you're don't get me wrong, I know how complex this is. Pharmaceutical companies are driven, by profit margins, etc. But instead of just having another version of a drug that's already been, that you can already use, and this is just them trying to better it or to extend their patents. If we could actually use real world data and use actually what patients are telling us to drive innovation, then I think we would be using resources. We wouldn't be wasting resources in the way that we currently are. So yeah, I completely believe that health technology is an integral part to how we are going to develop things in the future. I just think we need to get the structures around them right as well. I think we need to get the ethics around it, the rights around it, so that we're not having kind of conversations in the future that about how this data went awry and became used for different things. I think if we can build the structure, the use of AI, I don't know much about it, but I know a lot of people using AI in terms of modeling as well, drug development and things like that. So I think we've got a huge thing that we can use it for. It'll just be really interesting if we can get that right, and how the NHS can actually, it's such an immense system where you've got all these patients that, can we use that real world data that we're collecting on these patients to really to do a bit of a deal with the pharmaceutical industry and say, we've got access to all these people, how can we support, and then how can we ensure that when the drugs come back in, is at a price that we can afford. Kind of a lot was what Lowri was talking about. We've seen these situations in cystic fibrosis as well. So how can we use what we've got in the public sector and using technology to support that, but also, to bring that back into the patients and use resources much better.
Thank you. We are having a conversation with Pareto as well, because it's a very, very interesting company in Wrexham and working into several health technology intervention. But I would say there is a lag. There is a lag in terms of addressing accessing health technology, addressing the challenging that has faced health technology, such as like clinical trial and how to actually writing protocols in terms of clinical trials addressed in health technology and so on. And this presents an added barrier in adopting health technology. For example, like considering factors like adherence in clinical trials, it's not the same that like clinician based medication, which is actually adherence is actually having a very minimal margin of risk or like of accuracy in terms of the accuracy of the outcome. However, this adherence, for example, it becomes a bigger problem when it comes to health technology, especially self-administered. But do you think there is a lag in terms of this, and why this lag from your own point of view?
So yeah, I think there is a lag in terms of incorporating the technology. Is that where we're going with this? I think there's always a fear, especially within the NHS environment, of introducing something new. NHS technology is fairly slow. So we have a lot of clinical trials going on where we have to send data down. We're meant to be able to send it down the internet, but there is absolutely no chance we can do that because of firewalls, etc. So I think there's fundamental infrastructure issues that we need to tackle. The NHS blocks everything, which is understandable, but we also do need to try and find a way of getting it out. I think COVID has done a lot in this space in terms of decentralizing trials to take them out into the community. So yeah, I do agree there's a lag, but I do think COVID has accelerated these conversations and this actually happening. From my perspective, I think these kind of trials are incredibly important within the paediatric space because we are taking children out of a hospital environment and giving them an opportunity to be a child whilst they also participate in the trial, so they're not being stuck in that environment, in the hospital environment, when they can be with their friends. So I think they're hugely important, and I think we do definitely need to kind of keep working towards that. But there's also then access, isn't there? There are parts of Wales where people potentially can't access the type of technology that is necessary in order to the smartphones, etc. So I think we need to consider the widening of inequalities as well then in terms of using health technology. I don't think it's probably as bad as it would be in some countries, in some African states, etc., about being able to use the technology. But I think we've got some work to do. I think there is a lag, but I do think if we've just got to get used to the technology, and the NHS isn't very good at getting used to new stuff. It just has to get there, I suppose. That's what I feel from my perspective anyway.
Can I come in there as well? Because I think for me, technology has got a lot to offer, for people with learning disabilities, for example. And I think it's important that when we're thinking about it, then we include that sort of notion about inclusive design, and really think about, not just the one size fits all. I mean, I think we saw in the pandemic, assumptions being made, people with learning disabilities wouldn't be able to do X, Y, or Z, in terms of electronic communication. Actually, with the right support, a lot of people proved us wrong. So there could be a danger of either excluding people with learning disabilities, because we don't think they will cope, or there could be a danger of excluding them because it gets put in the too difficult box, because we might need to approach it in a different way and we might need to provide additional support. So I think it's got a lot of potential, but I think we just also need to be aware of the danger for further inequalities or inequities to arise from it.
That's a very, very good point. Thank you so much. This is a very good point.
Thank you, Rafiq, for bringing us onto that ground for our discussion, and to Rhian and Ruth for their responses. Olivia has a question.
Thank you very much. My question was actually going to be about technology. Rhian, you'd already mentioned the digital environment, and I was interested to know about the opportunities, and actually it's interesting to hear about potential barriers as well. So I guess really my question is to Lowri, to ask her a similar question about the patients and the groups that she was talking about. Whether you see any kind of opportunities through technology and the digital environment.
Right, thank you. Yeah, I think so. I think in terms of information sharing, I think it's a really important tool. I think particularly if if we're dealing with issues around neglected diseases, where perhaps we are looking for the most effective treatment for a particular disease. So I think technology sharing is particularly important. As an information tool, I think it's really important. And I think I would echo what Rhian said about the point around clinical trials and sharing data as well. I think that it could be a way to really cut down on some of the times in research and development for particular treatments, if we can use technology in a way that makes it more efficient to do these trials or to carry out this research. Although I appreciate the complexity of some of the the issues that we're talking about there. And yeah, I think that definitely something further to explore, I think. But yeah, I think it's a useful tool going forward. And I think perhaps we need a little bit more research in exploring how we can use technology effectively in this sphere.
Thank you.
Thanks, Olivia, and thanks, Lowri. I just want to throw something in before I come back to our speakers and ask if they would like to ask each other questions or summarize, come to a point. Something that's emerging is multiple strategies for improving outcomes, like technology, like human rights, like policy. And it's a very detailed point I have. It's a question I have for Ruth, I guess. Again, I'm intrigued by the over-medication point. And thinking about it purely in legal terms, Lowri and Rhian will appreciate this. That looks to me like a case of negligence. That the law on negligence would look like. I know it's a nasty word, doesn't have as much positive resonance in this context as human rights. But that's where that would go. Is that a way of protecting the interests of people with disabilities in this context? Does it come up?
I've not seen it come up particularly in relation to just purely medication. I mean, there certainly are challenges which are sort of ongoing about sort of inappropriate care, which perhaps medication would be part of that. So there have been some legal challenges, perhaps where families have had a family member who has had to go some distance away from home, has been kept within a setting which is not, from a human rights perspective, would not be viewed positively, and maybe been over medicated. So that it's been come up in that. But I think it's an interesting one in terms of negligence. I think where you might also have an issue in relation to negligence would be review of medication, because such medication might be appropriate for a short period of time to help that individual to restabilize. But actually, if that medication were used, it's being used for a sedating effect, and it's just used ad infinitum without review and looking at side effects and monitoring and appropriate things like that, then I think yes, certainly there I think you would have an issue with negligence.
Thanks, Ruth. Yeah, no, I started my life as a private lawyer, contract and tort, and I've never really shaken it off. And in a period before human rights were as dominant in this field as they are now, thankfully. I said I'd ask you to ask each other if you've got any points on each other's papers. We'd very much, I know Olivia was mentioning this to me too in the chat, we'd very much welcome that, to hear any reflections you have on the themes that have come up. I'm not going to pick on anyone, so let the spirit move you.
I'm happy to go ahead.
Thank you, Rhian. That's great. Yeah.
It was really kind of some of this. I've written some notes about that. Lowri was talking about incentives and corporate structures and stuff earlier, and it was really kind of wanting to have a bit of a conversation, because I think in terms of greater accountability, pharmaceutical industries, there's a lot of very kind of clever people who understand how to get around stuff in the pharmaceutical industry, and we've seen this in the kind of paediatric regulation. So we've got a regulation that's there to stimulate this drug development in this environment, and they have done incredibly well at just completely avoiding the areas where there's the biggest unmet medical need in paediatrics, and just gone because they know they just have to pretty much push their adult pipeline and only do the peds trials where they're necessary. That we're still kind of in a position where we're not seeing the important areas being kind of driven and stimulated. And then really, I don't know how much you know about the new kind of the new legislation they're trying to push through in the UK around the Better Business Act, and this kind of change to section 172 of the Companies Act, and trying to change, so it's more of a stakeholder kind of responsibility of companies as opposed to just a shareholder. And I'm just wondering from your perspective kind of what your thoughts are on how we kind of use incentives and use legislation, but really to stop pharmaceutical companies working around them, because they're very good at working around these things and then still making quite a considerable amount of money. So yeah, just any thoughts you've got.
Yeah, I think, yeah, definitely. It'd be good to talk further, I think, because I think one of the issues that we see is, translating the statements for international level and translating that into actual, tangible actions at domestic level or regional level, so that we can see, effective outcomes for patients. So I think it's definitely something that is necessary to explore. I think, some of the discussion around incentives, I think, looks at or suggests ways of putting forward particular prizes or awards or rewards for developing, particular product or medicine, which I think is a positive. But I do think that because of the complexities around research and development, it perhaps isn't always going to be the most effective way to do that. I think that other suggestions are not, we've got the carrot, but we've got the stick as well. So we've got the naming and shaming, but whether that's really going to bother major pharmaceutical companies, then I don't know if that's going to be particularly useful. So I think that there is a need to look at incentives, and I think perhaps we haven't quite found effective ways to do that. But I think that that's definitely something that we need to do to make sure that we're linking up state obligations that are agreed at international level, so that this filters down, so that we are seeing those having an impact for individuals.
I agree. I've got a colleague who works, so what we try and do is do a lot of work kind of cross-sector. So I work with a colleague who works for Novartis in the US, maternal and child health there, and she has tried to draft a different bill in the US around incentivizing neonatal drug development, because again, this is an area where things haven't happened for about 30 years. But her incentive, she's pharma, so her incentive is very much, you can get this voucher that you can transfer to any one of your blockbuster drugs, and you can have an extra 6 months in that. I mean, that the US Congress, etc., pushed back and said, well, no, actually, that's going to cost us a fortune elsewhere. So I think at the moment we're allowing the pharmaceutical industry to work out what incentives work for them, but it doesn't always work in the other direction. So I think, yeah, it'd be great to have more of a conversation with you on this and how we hold them to account a little bit more.
Yeah, that sounds really great.
Thank you both for that. My offer still stands. That was great stuff.
Yeah, I suppose for me, I mean, just thinking, Rhian, there's obviously there's areas of overlap between our areas of interest, and I'm just thinking, even within children, you're going to have subpopulations, for example, of children with learning disabilities, and so there's probably potential for further discussion there as well, because I would imagine, I mean, children with learning disabilities would be one, but I think the whole thing around intersectionality and different sort of elements which may impact upon this would be interesting to explore.
Yeah, that would be great, because a lot of the trials we do are very much focused towards children who have certain conditions.
Yeah.
That would we don't do trials just for the sake of doing trials. We tend to try and make it relevant to our patient population, just because we've got a limited infrastructure. So we try, we've done COVID work, etc., but we do try to narrow that down, and children with TS and epilepsy, that kind of stuff. So I can show you crossover.
Thank you, Ruth and Rhian. Lowri, do you have a question?
I think it was kind of Rhian's probably already got there first, because my question was kind of around what you're talking about, accountability for businesses in the UK. So I think, yeah, I think you beat you to it.
A really great session. I'm really, it's so heartening to see these issues being discussed with such precision, with such focus on legal policy, issues focused on particular communities in relation to health. And it's really been a great exhibition, I think, and a great demonstration of the strength of this initiative by the Learned Society of Wales to build ECR networks and bring us all into conversation about these key issues. So I thank very much our three speakers again for all the work they put into preparing and talking and discussing, fielding our questions and each other's questions. And I also want to thank Olivia and Barbara for organising this session so very well, giving us a clear running order and backgrounds and so on. So thank you both. Diolch yn fawr I chi, diolch yn fawr I bawb.